Thank you. So, I'm David Shutt. I'm the Medical Director for Barnsley Healthcare Federation. I was asked to give this talk by Dr. Ghani quite a few months ago because we had an unfortunate episode of a patient who died as a result of sepsis who'd attended the iHeart service. So following that, we obviously carried out a serious untoward incident investigation, had lots of actions from that, and we've changed a lot of the way we look at sepsis and how we deal with sepsis in iHeart and also in all our practices. So it was suggested that there was a lot of potentially useful learning that has come out of that would be worth sharing with everyone else. So I'm going to start off with presenting the case, just then a little recap about what sepsis is, why it's important for primary care, what did we do at BHF to try and improve things, and then some useful resources if you're wanting to implement some changes yourselves. So you may be familiar with the case or aware of the case because obviously it was mentioned in the iHeart CQC inspection that there had been a death from sepsis. It's been mentioned in the local press fairly recently. The family of the lady who died put a press release out for World Sepsis Day, which was last week, and that's actually been published nationally. They're more wanting to raise awareness to try and avoid this from happening again. It wasn't a critical piece of information, but I think it was in the Chronicle, the Star, the Yorkshire Post, and I think even the Mirror ran the story as well. So it involves a 23-year-old female who was a trainee paramedic as well. So it's a really tragic story. She was seen in the iHeart Extended Hours Clinic back in December, complaining of a few-day history of just cold-type symptoms, a dry, tickly cough, and a sore throat. So she was given an appointment at, I think it was Woodlands Drive, went down there and was history and examination, and there were observation findings at that time. So she had a temperature of 37.1, pulse rate was 68, respiratory rate 18, oxygen saturations were 97. It's documented that she had no cervical lymphadenopathy and a fairly normal ear, nose and throat examination. She looked well, and I'm sure you'd all agree it's quite appropriate to diagnose a viral sore throat in this situation. No antibiotics were prescribed. She was advised about symptomatic treatment with analgesia, fluids and rest. And she was given safety net advice that if her symptoms were to deteriorate or get worse, she needs to seek further medical attention. 4 days later, she again got back in touch with the iHeart service and again was seen in the Extended Hours Clinic by the same clinician that had seen her 4 days previous. On this case, her sore throat had got worse and she was just feeling a lot worse in herself. So she was seen again in the out-of-hours clinic, extended hours, sorry, but this time she had a very high temperature of 39. Her pulse was 136. Her respiratory rate at the time was 18. Her oxygen saturation is 99. She had halitosis and there was an exudate on her tonsils. Okay. It's also documented that the clinician felt that she appeared to look well. Okay. So this time she was diagnosed with an acute bacterial tonsillitis, prescribed a course of oral penicillin, and it was 500 milligrams 4 times a day for 10 days, and given some safety netting advice. And it's documented in the records that the patient was happy with the advice that was given. However, less than 24 hours later, actually within quite soon after, she deteriorated further at home. She was staying with her grandmother, and she started to become delirious. She started vomiting. Paramedics were called, but they were unsuccessful in resuscitating her. She collapsed and she didn't make it to hospital alive. It was obviously quite devastating for the family, devastating for her colleagues, because they worked with her as well. So really tragic circumstances. The cause of death was found to be an invasive group A streptococcal infection. So when obviously this came to our attention, we looked back and said, was there anything we could have done differently? And I don't know if you can see, I've put the observations in red. So there may have been a couple of pointers in that second consultation. So if we're using these guidance tools, which we'll talk about in a bit more detail later on, her patient, the condition had deteriorated, there was ongoing deterioration, her physiology was abnormal in the context of a probable infection. So we need to be thinking, could this be sepsis? She also had a red flag. Her pulse rate above 130 is a red flag for sepsis. And if you put all of the observations and work out her news score, she scores 5. We'll talk about news score in a short while as well. So if we're following this sort of suggestions, this flowchart here, she had red flags. We should have really treated her as red flag sepsis and admitted her at the time. So obviously there's definitely room for improvement, hence the serious investigation that's followed on from that. So can we play the first video? So I'm going to now just talk a bit about sepsis in general and ways we can... Just pause it a second, sorry. Just pause it. So I apologise for the American accent on this video, but it is a really good video which is useful for explaining in a really simple way what sepsis is. You can use this to educate your patients if you're concerned, but it's really good for training your sort of reception staff in recognising sepsis as well, because sometimes they're the first sort of port of call of patients coming into the practice. Okay.
Every 3 to 4 seconds, somebody dies of sepsis. Sepsis is an emergency. Sepsis is the final common pathway to death from the vast majority of infectious diseases worldwide. It arises when, in combating the infection, the immune system damages a person's own tissues and organs. This can lead to organ failure and ultimately death. Most infections can lead to sepsis. Among them are common infections such as pneumonia, urinary infections, infections in the abdomen, skin or wound infections, or meningitis. Seasonal flu, malaria, dengue and yellow fever, and Ebola may all result in sepsis. More than 80% of infections leading to sepsis are contracted outside of a hospital. Anyone can get sepsis. People with a weakened immune system are especially at risk. This includes adults over 60, young children under 1, people with chronic disease of the lung, liver, or heart, people with diabetes or AIDS, and people without a spleen. But sepsis can be prevented. The easiest way to prevent sepsis is preventing infection in the first place, which can be done through vaccination and basic hygiene. If an infection has led to sepsis, it must be recognized quickly, and the source of the infection treated with antibiotics. Early treatment of infections and early recognition of sepsis saves lives. Sepsis can be detected by symptoms like slurred speech or confusion, extreme shivering, muscle pain, fever, passing no urine all day, severe breathlessness, feeling like you're going to die, skin mottled or discolored. Sepsis is the most preventable cause of death worldwide. It affects 27 to 30 million people a year. 6 to 9 million die. Many survivors face long-term consequences, such as loss of digits or limbs, poor memory and concentration, or post-traumatic stress disorder. It can be prevented by vaccination, sanitation measures, such as access to clean healthcare facilities, and clean water, clean delivery, and, above all, awareness. You can help end the sepsis crisis. Tell your loved ones. Participate in World Sepsis Day on September 13th every year. Donate to support us in raising awareness, prevention, and research. While you were watching this video, 55 people died of sepsis. Sepsis is an emergency. The more people know about sepsis, the safer everyone is. Stop sepsis. Save lives.
So obviously some quite alarming statistics there. Certainly the number of people who've died whilst we've been watching that video in such a short time. Yeah. So as kind of summarised in that video, sepsis, it's a rare but it's a life-threatening condition. It occurs when the body's own response to an infection starts to cause damage to the own tissues and organs, resulting in organ failure. It can occur in response to any infection, be it bacterial, viral or fungal. And if it's not treated properly, it progresses rapidly to septic shock, multiple organ failure and death. So I'm just going to talk about some definitions. Now, there are some old definitions which you may be familiar with, which have gone out of fashion now. We don't tend to use them. So people may have been, if you worked in hospital, familiar with the SIRS, or Systemic Inflammatory Response Syndrome, which is your physiological changes in response to a trauma or an insult. And sepsis used to be defined as SIRS with a proven or presumed infection, so SIRS caused by infection. They also talked about severe sepsis, which was sepsis with evidence of organ dysfunction or hypotension, and septic shock, which is sepsis with severe hypotension needing sort of inotropic support, not responsive to fluid resuscitation. Now, that's been simplified. There's a World Congress, and the latest one, Sepsis 3, have defined sepsis as life-threatening organ dysfunction caused by a dysregulated response to infection. And septic shock, so whereas sepsis, vasopressor therapy is needed to maintain arterial pressure. So sepsis shock is kind of really bad. It's the end stage, and it's got an extremely high mortality rate if we get to septic shock. So why is it important to know about sepsis in primary care? Well, in the UK, 44,000 people die every year from sepsis. Now, that's more than die of breast cancer, bowel cancer, and prostate cancer combined. So there's an awful lot of people affected by sepsis. Globally, 6 to 9 million people a year die of sepsis. And 70 to 90% of these cases arise in the community. So they're not in hospitalised patients. The infection develops outside. Sepsis presents as a clinical deterioration of common infections, preventable infections, flu, chest infections, ear infections, sore throats, urinary tract infections, gastroenteritis. All of these things can, cellulitis, can cause sepsis if not treated at an early stage. And it's frequently underdiagnosed. It's commonly missed. And the case I've presented, it's not an uncommon finding. When they review deaths from sepsis, approximately 2/3 of them have had sort of less than good quality care. So there's always something that could have been done better, which may have improved the outcome. So detection and early management of sepsis does need to be improved if we're going to make an impact on these figures. So why is sepsis important? We've got another video that just kind of illustrates the impact of sepsis.
As a GP, I see many cases of sick children, and most of these, of course, will have viral infections or localized bacterial infections, and they'll get better on their own. However, time and time again, we hear of cases where sick children have been taken to be assessed at GP surgeries and even to A&E departments, but for some reason the clinicians assessing the child fail to detect, record, or even consider an underlying developing sepsis. But the challenge for all of us is to ensure that we have the skills necessary to be able to pick up those children who are developing the features of sepsis. In short, we need to think sepsis.
When she initially died, I was led to believe that she died of something incredibly rare, and we were just very unlucky. But actually, it seems now that it's not that rare, and if it had been spotted earlier, she would be alive. She had a cold and it wouldn't shift. but I didn't think anything of it because kids get colds. But this particular one wouldn't shift. Normally it would go within a few days.
I took her to the GP in the morning and we saw a young doctor in our practice, and she examined Maud and did all the things that one would expect. Took her temperature, pulse, talked about the sort of chronology of what happened. We talked about the symptoms, and I said, you know, I'm here because I'm worried it's going to go to her chest. And she said, okay. And so I think she got the spatula and looked at the throat. So she addressed all the things that you would address to a child presenting those symptoms. As we left, and I said, so you're absolutely sure that it's not going to go to her chest? And she paused and went, actually, why don't you go down the drop in A&E? So, you know, that was great of her to make that decision, but it was something that she decided she should do. She wasn't working from a book. She wasn't working from a system of care. That was a moment of clarity that she should do that.
The next day, I noticed that her breathing was really laboured. She was really struggling to catch her breath.
It was deep breathing. Her chest, which I now know to be called a stridor, was starting to happen. She was listless.
Yeah.
Her eyes were rolling. And she was catching her breath. And I said, immediately, let's just go. So we picked her up, took her out, got her into the car, and it was terrifying. We thought she was going to die there in the car. And this happened really quickly. So you can imagine in the morning, you know, she was fine, having the sore throat, and then throughout that short period of time, it had got worse. Bessie came in and she said she'd been playing with Maud, but that she couldn't wake her up. I went in and she was in the cot, face up, and she was dead. She was pale, she had blood coming from the corner of her mouth, and I knew she had died. So I was just calling her name, and I picked her up, and she was dead. And then I took her out into the hall, and Clara was screaming, and I was calling her name, Maud's name, to try and shout to wake her up, and Bessie was I don't know what was going on, and I took her upstairs. I held her, took her upstairs, and I remember Clara saying, "What's wrong?" And I said, "I think she's gone." And then I took her up, came up here into this room, and I put her on the floor, and I tried to save her.
I've spent almost 20 years looking at children with sepsis. And it's so frustrating and upsetting each time we hear of another case who wasn't diagnosed early and who has died unnecessarily. The clinical features of sepsis are often attributed to other conditions, and the clinical features of infection in that blood compartment, you have to think about it as a separate compartment. You have to think about the infection being in the bloodstream and how it affects all the organs in the body. And if the heart rate goes up very high, sometimes people think it's due to the fever, or they think it's because the child is agitated. Similarly, when the respiratory rate goes up, people think that's because it's due to a cold. And so you can see that the symptoms of the infection within the bloodstream are just often attributed to other causes, even if they can't see infection in those areas. And so the constellation of clinical features is missed. The one feature of sepsis that makes it even more difficult to spot is that the children remain alert, they're talking, And this falsely reassures doctors and even their parents, because they feel that if they're talking, they can't be that bad. But in fact, where the infection is in the bloodstream, things are going very badly wrong, and there are a lot of signs to see there. You need to be able to put them all together. And we will only get doctors to do that if we change the way they think, and we get them to think sepsis each time they see a child presenting acutely ill.
I sort of think of my life now as in two parts. You know, there was my life before and, you know, my life since. You do learn to live with it. You have to keep going, but it has just been completely devastating.
If you are a GP, remember that sepsis can result from many common infections. So when you see a child who's unwell, think sepsis. Measure and record their vital signs, including their conscious level, and alert their parents or carers to the clinical features that could indicate a worsening in their condition, particularly if they start to appear drowsy or confused. If you suspect sepsis, send the child to hospital fast and alert the hospital to your concerns. If you are in hospital and you suspect sepsis, immediately do the following: arrange for immediate senior review, give oxygen, take bloods including cultures, glucose and lactate, give intravenous antibiotics, give intravenous fluids, continuously monitor the child, and if you are concerned, call intensive care.
To find out more about sepsis, how to recognise it, and what to do when you see it, do have a look at these links, where you will find a really comprehensive range of educational and clinical resources.
So that obviously illustrates the impact of sepsis and how difficult it can be to pick up sometimes. She saw a GP, she was seen in A&E twice, yet despite that no one detected sepsis, and she wasn't treated, and unfortunately she died. So the various risk factors, certain groups, as mentioned in that video earlier, that are more at risk of developing sepsis, and that's the extremes of age, so that's the very young children, under 6 months, less than 1, and the older, over 65s, increased risk of sepsis if they get an infection. It's more risk if you're pregnant, or if you're immune suppressed for whatever reason, having had recent chemotherapy. That in itself is a red flag for possible sepsis. Long-term steroids, again, immune suppressants, so that can increase your risk of sepsis as well. Patients who've had recent surgery or recent trauma, again, another risk factor, as well as those who've got long-term catheters or other indwelling lines as well. So what can we do to try and pick up sepsis earlier? As it said in that video, think sepsis. Any patient presenting with an infection, think sepsis, and do your best to try and rule out sepsis until it's proven otherwise. Identify the patients who are presenting with sepsis or at risk of developing sepsis. Do our best to prevent sepsis developing in the first place, so increasing our uptake of vaccinations and the usual infection prevention control measures that are undertaken, hand washing between patients, things like that. There are lots of resources available that we can use in primary care, kind of to just make us more aware, jog our memories, and support our decision making. So you may all be familiar with the pop-up protocol that occurs in System 1 or EMIS if you type in fever or some abnormal observations, and certain keywords do trigger that, abnormal observations. The downside of that is if you free text your observation findings, it doesn't always pick it up, so it has to be entered in a numerical format or coded so that the protocol recognises it. One of the things we found when we looked into this specific case was that the out of hours module, and I really don't understand why this wasn't the case, didn't have the sepsis protocol embedded automatically. It's just, it wasn't there. So when we turned it on and tested it, I went back and put this patient's details into there to see would it have made a difference, because the observations were recorded as free text. They weren't coded or entered into a template. and it wouldn't have triggered despite the severely abnormal observations. If you put them into a template or code it straight away, it flashes up think sepsis. So it is a good alert. The RCGP have got a sepsis toolkit on their website, which has got loads of useful information which for training and awareness and supporting. There's some nice guidance that was released in 2016, and the sepsis decision support tools are linked from the RCGP toolkit, but they're available from the Sepsis Trust. We'll show you, you can also get them on the BEST website as well, and at the end I'll show you where you can find them. So that's what the sepsis protocol looks like. When it just jumps out at you when you're in the middle of your consultation, prompts you to enter further observations so that you can get a proper risk stratification, and it comes out, is this low risk of sepsis or high risk of sepsis, red flag sepsis, and it gives you sort of information as well on how to manage that. Useful thing I find is it gives you the prompt to print out a patient information leaflet for a safety net as well. If you're low risk of sepsis and you're going to manage them in the community, you can give them written information that tells them the signs to look out for, and it's just a simple click away from that. However, I think it was in Pulse in January of this year, there was an article that NHS England admitted that these protocols were very sensitive, and they were just coming up, you've seen it just comes up every time you enter something remotely linked to an infection. So they were over-triggered, and what that did, it led to GPs ignoring them. So that does happen, and since we've turned on the protocol alerts for iHeart, it's been triggered over 500 times, about 536. Now, only a handful of them, about 7 or 8, it came up as red flag sepsis, the rest were very low, but there were quite a few that had not gone on to that sort of assessment because it had been ignored. So there were quite a few instances where the alert's been triggered and it's been ignored. Now, sometimes it's obviously not appropriate. I've had situations where I've ignored it because it just doesn't fit with the clinical picture. But if the patient was to go on to develop sepsis and you haven't got a good reason for ignoring that alert, they'll hold it against you in a court, in an inquest. They're not going to take into account the fact that these alerts come up too often. So if it does come up and you do choose to ignore it, make sure you can justify that decision with your documentation. So that's just the Sepsis 2 kit that's available by the RCGP, so various different resources where you can get more information. And the nice guidance, first page is just general about how to identify patients that could have sepsis, how you should assess them, what the risk factors are. So again, it's useful information to have to hand. And there's different flow charts depending on the age of the patient. So under 5s, 5 to 11, 12 to 17, over 18s, because all of the observations that trigger a red flag sepsis are slightly different in each age group. These are the ones that are available from the Sepsis Trust, and I think you've all got copies of them on your table as well. I like these ones because if you print them out in colour, they're red, they're really visible, and I think we've since the incident happened, we've got these in every clinical area, in iHeart, in GP streaming at the hospital, in all of our practices. Each clinical room has a copy of them in eyesight of where the clinician will be practicing, so they've just got that sort of trigger that could this be sepsis, and the observations that prompt a red flag emergency are there easy to hand. So again, there's 4 different ones. There's one for under 5s, there's one to 5 to 11, there's non-pregnant adults 12 and over, and sepsis in pregnancy. Again, slightly different flow charts there, but you should have a copy of them all. News 2 scoring. So News is the National Early Warning Score, which you may or may not be familiar with. It's used all the time in the hospital. Their observations charts, it's built into that. But we're not so good at using scoring systems like this in primary care for observations. So News is a scoring system that can be used to assess the severity of an acute illness, so any acute illness, and it can be used to measure and identify any deterioration or also any improvement in the patient's condition. ensuring that you have a timely response to that. So this is what it looks like, and again you should have a copy of that on your tables. There is an app available for it as well, I think for both Android and iPhone, where you just click on the numbers and it gives you the news score and prompts you on how you should be responding to that. That's kind of how you interpret it. So it is a hospital-based tool and it hasn't been validated in primary care. So that's why the response there. A score of 0 to 4 suggests a ward-based response. Over 5, again, you're starting a more an urgent response, and 7 or more is an emergency response. Okay. The guidance also says if their news score is 5 or above, think could this be sepsis? If you remember this case I presented earlier, her news score was 5. So again, there was another potential prompt there that could have suggested the patient had sepsis. If your news is greater than 5, you've got a 13% mortality. If your news is greater than 5 and there's one red flag symptom for sepsis, your mortality increases to 23%. Okay, so the higher you're scoring, the worse the potential outcome. I'm going to show a video in a moment, but basically where it's useful, because it hasn't actually been validated as a predictor in primary care, but it's really useful for communicating if you're referring patients into hospital, with the ambulance service, with the assessment unit or A&E. If you tell them that patient's news score is 7, they know what that means. They know this patient is sick, and they know that it's a priority and to have an appropriate response ready when the patient arrives. So this video just illustrates that as well.
I came in because I already had an appointment to have my leg dressed, but I was determined I wanted to speak to somebody because I felt rotten at the time. There's only one place I wanted to be, was to see a doctor, to be honest.
I was presented with a situation where during afternoon surgery I was called by one of my practice nurses who was seeing Paul for a dressing change. She was worried that Paul was unwell and felt that he needed to be seen straight away because she was concerned about him. I suspected he was septic from cellulitis, which was a problem he'd had several times previously. That's why I carried out a news score to try and quantify that assessment. And I'd recently been to a talk by a local GP who was talking specifically about news scoring, so it was fresh in my mind. And so that was, I suppose, the trigger that made me, in that situation, decide to do it. It was quite apparent when I started to examine Paul that his news score was going to be high. He had low oxygen levels, he had a very fast pulse, he had a high temperature, he had low blood pressure, and he was really quite unwell. So when I calculated his news score, it came out at 7, which is significantly elevated, and I knew immediately that I needed to send him into hospital urgently by 999. When the ambulance came, the advantage of having done a news score was I didn't have to repeat all the basic observations that I'd done. Just telling them the news score and handing them a letter was enough for them to know that he needed to be taken straight up to the Accident and Emergency Department for further assessment.
This stood out for me quite actually straight away. Handover straight away, news score. He scored him straight away, and I must admit we don't get that very often. So that was one of the things that stands out. In the ambulance now we have these things, which are our electronic paperwork, so they replace our pad of paper. If you put in all the patient's observations, they will automatically give you a news score, and when we remonitor, we can see whether he's improving or deteriorating. And that's what we did with Paul, is that we put all his observations in, and his news score was 8 with us. Once you give the very basic handover, you then can actually say he's newsing at 8, and instantly, because the hospitals are used to using news scores, they instantly recognise what that means. It's a new thing for us to be able to hand that over, but they recognise, right, they can make that decision then where that patient needs to go.
By the time he arrived with us, his new score was 9, and it was the first time we'd ever seen a time frame where the new score was deteriorating because it had been calculated at each step in his pathway. So with the GP it had been 7, and then he'd been picked up by the ambulance service and they calculated it and it was 8, and by the time he got to us it was 9. And so it was clear that he was not only unwell but he was deteriorating as well.
So the video goes on to show that after treatment in the resus department, his new scores within a few hours started to improve because he was fluid resuscitated, he'd had antibiotics within the first hour, so it did show an improvement as well. So its downsides is it is only for patients over the age of 16. It hasn't been properly validated in primary care, but it is a useful tool for communication and handover, and its use is recommended by the RCGP. It's not a replacement for clinical judgment, like any of these tools that I've shown there. If you think the patient's unwell and they're not triggering, I would still act on your instinct. However, if the triggering is scoring very high, I'd be very cautious about ignoring it. But that in mind, there will be several patients you have on your lists that will have a high new score anyway, with chronic COPDs who've got low saturations. So one or two will spring to mind. So there's another thing here, QSOFA. Now, I wouldn't worry too much about QSOFA, but QSOFA is a scoring system for predicting mortality in intensive care. But it relies on these 3 things. So if you've got a new confusion or an altered mental state, an increased respiratory rate, or hypotension, any one of them will increase your mortality rate. Obviously, all 3 of them, it's really bad news. The reason I mention it, because these are the symptoms that you can easily pick up in primary care, even from a telephone triage. And if they've got them, there's a good possibility the patient has sepsis and they're high risk of a poor outcome. So if they're confused, the relative might tell you that. They may appear confused. They'll tell you they're having difficulty breathing or they're breathing faster. And if they're pale, clammy, cold to the touch, suggesting they're probably peripherally shut down and hypotensive. So if we're diagnosing more sepsis and referring people by ambulance if they've got red flag sepsis, it's really important how you hand over to the ambulance service to get an appropriate response. And I would encourage you all to tell the ambulance service that you've got a patient with red flag sepsis. Give them the news score, because it will mean something to them and it will help them to determine whether the patient's deteriorating or not. Now, this was interesting to me. We had an incident in one of our practices where a child with possible sepsis who was deteriorating waited 47 minutes for an ambulance to arrive. This child had an evolving petechial rash, had been given IM penicillin, but it still took that time to get here. So again, I followed that up with Yorkshire Ambulance Service and had a response recently. Sepsis is a category 2 response time, which is a median of 18 minutes response, but it could be up to 40 minutes you're waiting for your ambulance to respond. Now obviously I apologise for being outside of that, but they weren't much outside of that, which isn't that reassuring, to be honest. Category 1 obviously is your severe anaphylaxis and cardiac arrest, so it's not far off that, but I can just imagine sitting there waiting for half an hour with a really poorly child. It just doesn't bear thinking about. Documentation, really important in suspected sepsis, particularly for your physiological parameters. Many times patients who either die from sepsis or end up having sepsis, they've consulted several times with different clinicians in the early stages of the illness. And if you don't document what the findings were at that time, you can again be questioned, why didn't you think it was sepsis at that time? But if you've documented that your examination, your history, your safety netting, you've got that defence to back you up to say, well, actually at that time there was no evidence of sepsis. This has evolved, and then you can see that evolving change. Use the templates. System 1 has a really useful examination findings template, so when you put the figures in there, if it is going to trigger a response, it will, but again, it makes it easier. what it looks like, and it reminds you to do everything. Effective safety netting. So what I mean by that is just saying if it gets worse, come back again. That's not good enough. These patients, if they are suffering with sepsis, they've never felt this worse. They feel like they're going to die. It's really they're really poorly. So you need to be explicit about what you're telling them, and that's why it's really helpful to use written information, the patient information leaflets about treating your infection. They explain the symptoms to look for. But there's a really useful mnemonic, which is sepsis. So slurred speech or confusion, extreme shivering muscle pain, passing no urine throughout the day, severe breathlessness, you feel like you're going to die, or your skin's mottled or discoloured. They're all possible signs of sepsis and need to be dealt with urgently. Again, useful to reinforce with these patient information leaflets. And if your sepsis protocol does trigger in your system, there's an option to print that out at the time, and it documents that you've given them the information leaflet automatically as well. So my recommendations following all the work we've done is think sepsis. Okay, be aware of it, consider it. And there's another thing, the NHS England in their latest sepsis action plan have suggested all practices should have a sepsis champion. So I meant to change that before I did the presentation. Instead of consider having a sepsis champion, have a sepsis champion for every practice, someone who kind of promotes excellence in detecting sepsis and does audits on your detection of sepsis and things like that. So what did we do? Well, obviously we've raised awareness amongst all of our organisation. Sepsis is a regular agenda item on our team meetings, and anything new related to that is passed on. So there shouldn't be anyone who's working in our organisation who isn't aware of sepsis. There's training available through e-learning for health from the Department of Health. It's really good training on sepsis. We've made that mandatory for all our clinical staff, that they should complete that. We've got all these decision support tools that you've got available. We've got them visible in the clinical areas, so they're an aid memoir and useful. You're not having to look for them and find them if you want them. We've activated the sepsis protocol for the iHeart service as well, so that has made an impact. There's another thing I've done. There's a GRASP fever tool, which is an audit tool that's available where you can look at how well you're picking up and managing fever in under 5s. So it is slightly limited in what you can get from that. But I ran that for all of our practices, and the biggest downside was the observations weren't being coded, so it wasn't picking up as many. So again, the importance of coding your numbers and recording diagnosis. But it's a good way of seeing how well you're doing. Are you documenting red flags and traffic lights, symptoms and things like that? So various other resources that are available to help you. The e-learning for health, the RCGP sepsis toolkit. The RCGP also run courses. I think it's a free course, this building a sepsis aware system around general practice, and I can really recommend that. I went on that a couple of months ago. It's run by a guy called Stephen Stockhill, who's the RCGP champion for sepsis. He's really passionate about sort of improving outcomes. A really interesting session. And the Sepsis Trust, they've got a lot of useful information to try and promote and raise awareness amongst patients, so you can get order posters from them to display in your practice. Because we want to be getting patients to be thinking about it as well, thinking could they have sepsis, asking could we have sepsis, to try and prompt us when we might not have been considering it. Okay. So I wasn't going to include this, but Dr. Ghani's asked me would I include this short. It's a very brief sepsis quiz that I put together last week for World Sepsis Day. So have you all got the clicker things? And they are very easy answers. All of the answers have been in the talk before, so we won't spend too long on this. So how many people in the UK die every year from sepsis? majority were right, yes. Obviously some people arrived a little later than that slide. But 44,000, okay. What is sepsis? Is it a virus? Is it a mild self-limiting infection? Is it a life-threatening response to an infection? Or is it an intra-abdominal infection? Okay, yeah, excellent. So does sepsis only occur in hospitalised patients? True or false? Yes, obviously, it doesn't. That's why we're talking about it. And sepsis can develop from a cut on your finger, an insect bite, flu, a urinary tract infection, or all of the above. Yes, yeah, all of the above can cause sepsis, can't they? So which of the following are signs of sepsis? So rapid breathing, new confusion or disorientation, fever, hypertension, or all of the above. Sorry? No, it's hypertension I've put on there. So actually it won't work for this one because it's multiple choice. We didn't have the luxury of the buttons, so I do apologise for that. But yeah, the odd one, it should be which isn't a sign of sepsis, and hypertension, you're quite right. Okay, so I should have modified it for Dave, so I do apologise. So which of the following is not a risk factor for developing sepsis? Yeah, obviously stress isn't a cause. So how do we manage sepsis in primary care? Do we give them oral antibiotics? Do we give them diuretics? Do we give them an emergency hospital admission, or watchful waiting? Tell them to come back in a couple of days. Yeah, okay. So which, again, this one isn't going to work. So which of the following most predictive of sepsis? We'll have to do it as a show of hands. Is high temperature a reliable symptom for sepsis? No, it's not. It doesn't even come in the guidance for detecting sepsis. Is hypotension a reliable and predictive symptom? Yeah. Confusion? Tachycardia? Tachypnea? Yeah. The three most reliable are the hypotension, confusion, and tachypnea. Okay. Does sepsis develop slowly? Yeah, absolutely. Sepsis develops really quickly, so and things do change quite rapidly. And that's the end. So if there's any questions, yeah.
This category 2 response ambulance, is that written in stone? Because I have often had the response. You can either have a 999 or a 124. And when I told them, look, within an hour, good enough.
Okay. For sepsis, yeah. So for sepsis, you want an emergency ambulance, it's 999. But within the 999, there are I think it's 4 subcategories of priority. So category 1 is your cardiac arrests, your anaphylaxis. Category 2, it's still a blue light, it's still lights and sirens, it's as quick as they can. But yeah, and that's fairly standard across the country. They shouldn't, if you stress. And what they've said is they should have clinicians at the ambulance service as well. So if you're not happy the ambulance is taking longer than you'd like, and your patient's deteriorating, if you ring them back and give them the reference number, and if you ask to speak to one of their senior clinicians, you can put your case forward for a more priority. Obviously, the ambulance service are very stretched as well, and I think that was the situation we had with this 50-minute wait. They got this one there as quick as they possibly could, but yeah, unfortunately that is what it is.
Sorry, I think David is also going to tell us a little bit about BEST website and where to access sepsis tools.
So yeah, all of the useful information regarding sepsis is now being uploaded on the BEST website. So if you want to find it quickly, if you go to the diagnostic tools section at the top, and then scroll down, you'll see it says sepsis tools for children and adults. And it's all there, and it's all nicely set out, make it easy to find what you want. So Dr. Atcher's done a really good job of making it easy to find. Okay, so if you ever need any more, they're there. Okay, thank you.